All right, let's jump right into this high-yield masterclass on the urinary system. Today, we're going to trace the fascinating journey of renal function, and we'll guide you from a perfectly normal, healthy filtration system all the way to a state of complete system failure. Whether you're reviewing clinical pathophysiology or you just really want a deeper understanding of how our bodies handle waste and fluid balance, this explainer is designed to give you absolute clarity. Here's our roadmap for this explainer. First, anatomy and physiology. Second, UTIs. Third, acute pyelonephritis. Fourth, renal calculi. And finally, acute kidney injury.
Section 1. Urinary anatomy and physiology.
Okay, let's dive into this by establishing our baseline understanding of what a healthy urinary system actually looks like.
You can really think of this as the body's ultimate plumbing and filtration system. Notice the anatomical layout for both males and females. The core function here is absolutely essential for survival. Your kidneys are continuously filtering blood to create urine, which is basically a waste byproduct. But, it's not just about getting rid of urea. These organs are constantly making these tiny micro-adjustments to regulate your blood pressure, keep your acid-base balance completely in check, and manage the exact precise levels of potassium, sodium, and water floating around in your bloodstream.
Zooming in on the kidney's internal structure, we can see exactly where the magic happens. The outer cortex and the inner medulla are just packed with these tiny, complex filtering units called nephrons. Inside each nephron is a glomerulus. That's a microscopic ball of blood capillaries doing all the heavy lifting of filtering urea out of the bloodstream, while the renal tubule collects and refines that waste. It's an incredible piece of biological engineering.
Now, to truly understand the kidneys, you've got to understand how they defend your blood pressure. This is the notoriously tricky renin-angiotensin-aldosterone system, or the RAS. Let's break this hormonal cascade down step by step. So when your blood pressure drops, your kidneys sense it instantly and release an enzyme called renin. Renin travels through your blood, chops up a liver protein, and boom, creates angiotensin-1. As that inactive hormone passes through your lungs and kidneys, an enzyme called ACE converts it into angiotensin-2, which is this incredibly powerful vasoconstrictor that then triggers your adrenal and pituitary glands to release aldosterone and ADH. The end result? Your body stubbornly holds on to sodium and water, dramatically increasing your blood volume and driving your blood pressure right back up where it needs to be.
Section 2. Urinary tract infections, or UTIs. Now that we know how things are supposed to work, let's shift to our first pathological state, starting right at the bottom of the urinary tract.
And this brilliantly illustrates how most of these infections actually begin, with bacterial ascension. See, the urinary tract above the urethra is supposed to be completely sterile, but organisms, and we're most commonly talking about E. coli here, originate down in the perineum and physically climb up through the urethra. Because females have a shorter urethra and proximity to normal vaginal flora, they're at a much higher risk for this type of bacterial ascension.
So what are we monitoring clinically? Well, when that bacteria takes hold, it causes inflammation. Your patient is going to present with dysuria, that's painful urination, along with urgency, frequency, and this very distinct suprapubic pressure. To diagnose it, a quick urine dipstick will often light up with nitrites and leukocyte esterase, telling us loud and clear that white blood cells are in there fighting an infection. But listen, here is the absolutely vital takeaway for any healthcare professional. Catheter-associated UTIs, or KUDIs, are entirely preventable. Urological instrumentation introduces pathogens straight into the tract. So avoiding unnecessary catheterization and getting indwelling catheters out as early as possible, that is literally the best way to protect your patient.
Section 3. Acute pyelonephritis. Let's move to and see how this builds when a localized lower urinary infection is just left completely unchecked.
It successfully travels right up into the renal parenchyma, creating a much more dangerous condition called acute pyelonephritis. We really need to contrast these two conditions directly. Lower UTIs like cystitis usually stay localized, right? The patient feels burning and bladder pressure. But if that patient suddenly develops a fever, chills, nausea, and severe flank pain, specifically costovertebral angle tenderness, those are massive clinical red flags. The infection has hit the kidneys and has officially gone systemic.
And that systemic spread can quickly snowball into this, urosepsis. I want to highly emphasize this critical term. This is when the urinary infection spills completely over into the bloodstream, meaning your patient now has both bacteriuria and bacteremia. Make no mistake, this is a severe, life-threatening emergency. As a professional, you've got to recognize that shift from localized discomfort to systemic infection instantly, because this patient requires rapid intervention with emergency IV antibiotics before they completely destabilize.
Section 4. Renal calculi, or kidney stones. Transitioning away from infectious processes, we run into mechanical blockages.
Kidney stones happen when the normal constituents of urine lose their delicate balance. Things like a hot climate, chronic dehydration, and specific diets can actually cause crystal-forming substances to literally stick together.
But not all stones are created equal, and knowing the specific chemical profile changes your entire treatment strategy. The most common ones are calcium oxalate stones, often linked to excess oxalates in the diet. Think heavy tea drinkers or folks with high sodium intake. But look closely at how urine pH alters stone formation. If a patient has a persistent UTI, certain bacteria make their urine highly alkaline, and that breeds these massive struvite stones. On the flip side, if someone has gout or a diet really high in purines, their urine becomes very acidic, which causes uric acid stones. So treatment isn't just about managing pain, it's about altering the actual urinary environment to dissolve the specific crystal involved.
Now, what's really interesting about this slide is how we intervene for stones that are simply too large for spontaneous passage, usually anything greater than 5 millimeters. If conservative management fails, we turn to procedures like extracorporeal shockwave lithotripsy, or ESWL. Using ultrasound to pinpoint the stone, a generator fires these high-voltage, acoustic shockwaves straight through the patient's tissue. It literally shatters the solid stone into tiny, sand-like particles that can then be safely flushed right out of the urinary tract. But all of this brings us to a massive, looming question. We've talked about infections, and we've talked about mechanical blockages. But what happens when the body's filtration system completely and rapidly shuts down?
Section 5. Acute kidney injury, or AKI. This is a rapid, catastrophic loss of kidney function. When the system fails, you see dangerous, progressive spikes in blood urea nitrogen, creatinine, and critically, potassium, while urine output often just plummets.
To truly master the pathophysiology of AKI, you need to spatially orient yourself using the pump-filter-drain analogy. The causes of AKI are basically divided into 3 distinct categories based on exactly where the injury occurs. Prerenal causes occur before the kidney. Think of this as a failure of the pump or the blood supply. Intrarenal causes occur inside the kidney tissue itself, a direct failure of the filter. And postrenal causes occur after the kidney, a blockage down in the drain.
Let's look at the specific clinical triggers for each one. For prerenal, a massive hemorrhage or cardiogenic shock means the pump just isn't sending enough blood to perfuse the kidneys. For intrarenal, exposure to nephrotoxic drugs or contrast media causes direct chemical damage, destroying the filter from the inside out. And for postrenal, issues like a massive kidney stone, BPH, or prostate cancer block the drain, causing urine to physically back up into the renal pelvis, ultimately crushing the kidney with hydrostatic pressure.
Regardless of the cause, AKI generally progresses through distinct phases, starting with the very perilous oliguric phase. During this phase, urine output drops below 400 milliliters a day. Because the damaged tubules just cannot filter, fluid backs up systemically, causing things like pulmonary edema and distended neck veins. Furthermore, the kidneys completely lose the ability to excrete hydrogen ions or potassium, leading to a dangerous buildup of acid and an incredibly high risk of fatal cardiac dysrhythmias. Now, if the patient survives that, they enter the diuretic phase, suddenly dumping up to 3 liters of urine a day. So why does blood pressure suddenly plummet here? Well, because the kidneys can excrete waste again, but they haven't regained the ability to concentrate the urine. This leads to massive osmotic fluid loss and severe hypovolemia. This is starkly contrasted with the recovery phase, where the glomerular filtration rate finally increases and those waste levels drop. But remember, full recovery is agonizingly slow. It often takes up to 12 entire months for kidney function to fully stabilize.
So the crucial point is how we actually manage this acute crisis. Your priority is assessing intravascular volume and managing that hyperkalemia. You have to combat that life-threatening potassium spike fast. We use IV regular insulin to literally force potassium back into the cells, calcium gluconate to protect the heart's threshold from going into dysrhythmias, and K-exalate to physically evacuate potassium right through the GI tract. If conservative management fails, we move immediately to renal replacement therapy, basically acting as an artificial kidney to save the patient's life.
Which leaves us with this final provocative thought. The urinary system is incredibly resilient, for sure, but it is also exceptionally fragile. Even if a patient makes it through the oliguric and diuretic phases and their lab values return to completely normal, is the structural damage truly gone? Or is an episode of acute kidney injury actually a silent precursor to end-stage chronic renal failure years down the line? It's a sobering reminder that while the kidneys can recover, the battle for long-term health might just be beginning. Thanks for joining me for this explainer, and keep questioning the incredible mechanics of the human body.